You're listening to Medscape's In Discussion series on Hidradenitis Suppurativa, a podcast where thought leaders and clinical experts share their diverse insights and practical ideas for optimizing patient care. This series is hosted by Dr. Jeanette Okoye. Dr. Okoye is professor and chair of dermatology at Howard University College of Medicine. Relevant disclosures can be found with the episode show notes on medscape.com or the Medscape app. The topics and discussions are planned, produced, and reviewed independently of advertisers. This podcast is intended only for U.S. healthcare professionals.
Hi, I'm Dr. Jeanette Okoye. Welcome to Medscape's In Discussion podcast series on hidradenitis suppurativa. Today, we'll share a surgeon's guide to HS with our guest, Dr. Julie Caffrey. Dr. Caffrey is an associate professor of plastic and reconstructive surgery at the Johns Hopkins University School of Medicine and the program director of the Burn Fellowship at the Johns Hopkins Burn Center. She's a nationally recognized expert in managing complex skin and wound conditions. Dr. Caffrey, thank you for joining us today and welcome to the Medscape in Discussion podcast.
Thank you for having me.
So, Dr. Caffrey, you and I think, agree that surgery is such an important aspect of HS management. But I feel like, unfortunately, for most patients, it's offered as a last resort. But in my experience, the sooner patients remove as much of that affected tissue as possible, the better they do overall. Especially since we know that the chronic lesions, like the tunnels and the sinus tracts, they're active. They're actually contributing to their overall inflammatory burden. But I think the key is to find a surgeon who has some experience dealing with HS and who really wants to take care of these patients. And so when I think of experienced HS surgeons, I think of you. And I've been sending patients to you for, I think, over 10 years at this point. So I'm thrilled to have you here to share your hard-earned wisdom. So tell us how you came to develop your interest in or expertise in HS.
I first became interested in HS probably because I'm a burn surgeon, and my patients suffer from problems with their inflammatory pathway. And that led me towards being interested in patients who have other inflammatory diseases like HS. And not just that, but really being part of a burn center, you have access to wound care specialists like specialized nursing that allow you to better take care of some of our patients who have very late stage disease, who maybe need extensive white excision, who may need longer hospital stays. And so a lot of times those patients will be referred to burn center or burn specialists who aren't afraid of making a big hole because they know they can fill it. And I think that's probably how I first became interested in HS.
That's great. I am so grateful that you did, at the Johns Hopkins Burn Center. That's where so many of our complex dermatology patients were seen. I'm just glad you're still there. Tell us, how would you describe a good surgical candidate? So, for example, what characteristics of a patient's history or their presentation makes them suitable or unsuitable for surgery?
For me, it's about having control of the inflammation in their body that would make an ideal candidate. So a patient who knows what causes their flares, understands that it's important to do the medical therapy, right? I think a lot of times patients get sent to me and they think surgery is going to be some cure for them. And surgery is not a cure, it's really an adjunct to the medical therapy. And so I think patients who are on good medical therapy, follow with a dermatologist, have tried all of the things, meaning they've lost weight if that's a driver for them. They've tried an anti-inflammatory diet to figure out if gluten, added sugars, or dairy is a driver for them. They've seen an endocrinologist to find out if it's hormone driven in certain cases. And then really their disease is relatively well controlled. That's ideal. That's not always the patient that gets surgery, right? In a perfect world, that would be the patient that I would want to operate on.
And is that because you want them to have tried all the other things first? Or is that because you think if they have the anti-inflammatory diet on board, if they are not a smoker, for example, if they've optimized medical care, is it just that helps their surgical outcomes be better?
Yeah. So the big problem with surgery for HS is wound dehiscence. And a lot of surgeons don't like to do HS surgery because they feel like Well, if I cut this big thing out and I do all this work to put it back together, and then I get skin breakdown, that's a failure or a complication.
Hmm,
I just don't see it that way. I see it as wound dehiscence is not a complication, it's an expectation. But our
hmm,
goal is to limit the amount of dehiscence that happens. And the way that we do that is trying to prevent postoperative flare. And most patients will have some sort of postoperative flare in the first 2 weeks. And that's because surgery is also inflammatory. We can't prevent that. But what we can do is optimize. And so I think the rates right now we say is 50% will get wound dehiscence. Those are just any kind of skin breakdown. But if you excise an area that's, I don't know, 100, 200 square centimeters, and you get a wound that's 10 square centimeters that heals over the course of 3 or 4 weeks with a little bit of Aquacel AG, and the patient can still return to work or do all the things, to me, that's not really a complication. That's still a major win for that patient.
that's a bit of a paradigm shift, right? If we counsel patients even before coming to you or another surgeon and say dehiscence or wound breakdown, describe it to patients properly is expected.
Mhm.
I think that would really change the way patients experience their post-op period as well. So what surgical approaches do you use and which ones do you think give patients the best outcomes?
There's no standard of care for surgical management of HS. I consider myself an expert in surgical management, but I also respect a handful of others who I consider to be experts in the surgical management. And I would say of the three of us that I know well, we all practice very differently. And so there are some surgeons that still practice wide excision, leaving the wound open and allowing it to heal by secondary intention. There are pros and cons to that. One of the pros is you don't get a wound dehiscence, right? Because you
Right.
never closed it. The second part that's can be positive is that when wounds heal by secondary intention, they form more scar tissue. And I find that although HS can still find a way to form in that area, it's much less common. If you look at the studies, it says that wide excision and healing by secondary intention has less recurrence rate in the region that you excise, and that's probably due to the scar tissue. But it
Mhm.
also takes a lot longer to heal, can cause contractures and severe deformities. So pros and cons to that. Some people practice as I do, which is excise and primarily close or do adjacent tissue rearrangement to fill the defect. I think the benefits to that is that you have wound closure. You may get a small wound, but that'll heal in. The patient's out of work much smaller period of time. They're less likely to develop a wound scar contracture. And if you've chosen the right patient, they're less likely to develop an early recurrence of disease. That doesn't mean they'll never get a recurrence, but they're less likely for that to happen. And then finally, one of my other colleagues that also does a little bit of both, right?
Mhm.
So leave a little bit open, put a little bit back together. So again, all of those are options and they're not wrong. I would say the other major thing that I do when doing these operations or consider is for me, I make sure not to distort normal anatomy. So we used to do wide excisions, even if it distorted normal anatomy, it wasn't uncommon to perform a hemivulvectomy in a woman,
Yeah. Yeah.
a young woman. And for me, it's not cancer. My surgery is not going to cure this patient, and making them deformed is
Mm,
not right. And so I try to use adjuncts. I believe in reduction of disease burden, right, to help the medical management work. And then I use CO2 laser for areas that maybe I can't excise. Maybe a little CO2 laser, a little steroid injection here and there, and dry up those lesions or tracts,
mhm.
and leave the anatomy alone. And if the patient's controlled from an inflammatory standpoint and we reduced all the areas that could be excised, then most patients will do well and have some period of time that they're disease free.
I think that's such an important consideration, the anatomic distortion, especially in these young women. I have many patients who had surgery, many years ago elsewhere, and they don't have recognizable genitalia. And their HS could be as well controlled as we want it to be, they're still so impacted by the disease because of this, because it's left this permanent mark that affects their relationships and so on. So thank you for thinking of it in that way. I have two questions. One about the CO2 laser. Tell me about your use of CO2 laser. You're using it as a knife, so to speak, or are you removing the hair with the CO2 laser? Tell me more about that.
So a fractionated CO2 laser causes small micro ablations in the skin and into the soft tissue. It penetrates about 5 millimeters in depth. And I use it a lot in my burn patients to break up scar tissue. In HS patients, especially those who have formed tracts, the problem with the tracts or why they continuously fill is because they're lined by epithelial cells. That keeps them open. Burning all these micro holes into those tracks eventually destroys enough of it that they stop filling. Removing hair is also helpful, and over a period of time, you will get loss of hair follicles, but the CO2 laser is not a laser that's specific for hair removal. So I don't necessarily think that it's the hair follicle that gets destroyed. I think it has more to do with disruption of the epithelialized tract underneath.
And you said it penetrates about 5 millimeters. So for deeper tracks, how do you manage those?
So if they are deeper tracks, they usually need to be excised. But for the most part, in the areas that I'm using it, you don't have that. For me, the areas of the body that I use CO2 laser are the labia, the mons pubis, if it can't be excised, the beard line, and the posterior scalp. These are areas that are more challenging to reconstruct from a surgical standpoint, or you don't really want to put scarring if you don't have to. I wouldn't use it as a primary treatment, right? So not primary treatment for axilla, groin, perineum, buttocks, but for unexcised lesions in the labia, beard line, and scalp. So thinner skin areas where you can actually penetrate.
That makes sense. We share a patient who has had really nice results on the occipital scalp
Mhm.
and the beard area. So I'm a believer for sure. Another question I have is you mentioned adjacent tissue rearrangement, which for a dermatologist, I assume that's like a flap, right? Is
Yes.
it? When you bring this adjacent tissue over, it has hair follicles. So my question is, do you see HS developing within the flap now that it's in the right anatomic area? Or does that normal skin stay normal?
So the way I think of it is that any hair follicle can cause a problem. And
Mhm.
we have hair all over our bodies. For example, if I use the thigh to close the groin, can you still get recurrence? Yes, but it's not that common, right? So
Okay.
most of the time you don't get that, but you can. It's just like when patients say, well, you say you can get HS in any hair follicle, but most of the time people get it in their axilla and in their groins. Well, that's true. But I have a patient who has HS tracks on his leg. I have one that has them on their arm. So it can happen. I have one that has in the midline of the back. I mean, odd, but there. Those things can happen. I would say that recurrence is really based on how well you're controlled from an inflammatory standpoint, right? So how well you're controlled medically and not necessarily where the tissue comes from.
Okay. Makes sense. Do you ever use a vac?
Yes. So I use incisional vacs a lot once I close them, but for disease that is not amenable to closure, so those patients who bilateral buttocks, entire buttocks, and posterior thigh, you can't close those areas. Those patients I usually treat with a Veriflow wound vac. So that is an Instill-A-Vac that we instill with Bosch. And I usually use that for a week or two for two reasons. One, to remove bioburden, and two, because when you've taken off that much soft tissue, if I were to just graft that area, I would leave somebody with a very flat behind.
Mm,
And people don't like that.
no.
No. Oftentimes, I will use a Veriflow wound vac for 2 weeks to build granulation tissue, and then I'll add a skin substitute. Most of the time nowadays, I use BTM, biodegradable temporizing matrix, a synthetic, and really just because that one is very inexpensive. And so
Mhm.
if I have any loss. It's not the end of the world. And then that helps build more granulation tissue, so fills in that soft tissue defect, and then skin graft after that.
Long road for the patient, but much better outcomes. I love that you think about their post-operative life. I think that's great. You talked about the fact that really the chance of recurrence depends quite a bit on how medically optimized the patient is. So, I've certainly heard various opinions on whether or not we should leave patients on their biologics through surgery. The answer seems to vary by the surgeon. What's your opinion on that issue?
I think historically, we've always been taught that patients who are immunocompromised or are on immunomodulating medications can't heal wounds. Well, I'm a burn surgeon. I take care of patients with 50, 60, 70, 80, 90% burn injuries who are severely immunocompromised, and those patients still heal. And so I know that even if they remain on their immunotherapy, I'm still going to get the wound to heal. For me, taking the patient off of immunomodulating medications increases their risk of postoperative flare. And that is probably the worst thing that can happen. One, it will break down whatever wound we just closed. And two, it may cause increased disease severity in the areas that we haven't excised yet. So for me, I don't see any downside to continuing it. And I insist that my patients stay on it. And those patients who are not on immunotherapy preoperatively, who would like to be to optimize themselves, I start them on it and perform surgery 3 months after initiation.
So at least 3 months of the biologic.
And that's really just to reduce the amount of inflammation that they have so
Mhm.
that we have a better surgical outcome.
Okay, that's good to know. Are there any HS therapies you would stop before surgery?
The only therapy that I usually stop before is GLP-1s, and that's more so for the gastric emptying for the anesthesia side.
And what about perioperative antibiotics? Do you have a preference? Should we be starting our patients on specific antibiotics the week or two before surgery, or do you manage all of that?
So I usually manage it myself. Honestly, I don't have any good evidence-based practice for this. I am not a believer in the IV ertapenem 6 weeks study that came out. I am a believer in treating with something. And so I usually ask the patient, what antibiotic works best for you when you have a flare? And whatever that is, I give for 2 weeks postoperatively.
Okay. Oral, not
Oral.
IV.
Yeah, oral.
You're not convinced that IV ertapenem for 6, 12, 16 weeks kind of tease patients up for better surgical outcomes?
I'm not. I think it increases their risk of developing multi-drug resistant organisms in the future.
Okay. That might be some fighting words out there, but
Hmm.
I love the controversy because I think dermatologists believe that some surgeons want that. So this is very interesting, and I think we need to all get in a room and talk some more.
I think
You,
also you have to remember, as a burn surgeon, my patients develop really nasty bugs, right?
yeah.
And so seeing patients on chronic antibiotics, it can be really frightening when you run out of antibiotics to treat somebody. And so we need to be good stewards and we need to think about that. And so if this is a patient who's going to be on antibiotics most of their life for multiple flares
Mhm.
and have multiple surgeries, because most HS patients don't have one surgery and done. They'll come back at certain times in their lives where things change. Maybe it's they had a baby, or maybe they go through
Mhm.
menopause, or a 40-year-old guy whose testosterone levels dropping and all of a sudden they're getting new flares.
Mhm.
They're gonna have surgery again. And so we just need to be mindful and be good stewards of those antibiotics, because if we run out of them, we're in big trouble.
Yeah. And I think one's view of antibiotics really changes when you see what happens on the other side
Yep.
of drug resistant organisms. So thank you for sharing your opinion there. Do you think we're sending patients to surgery too late?
I will say I have seen a shift in the past few years where patients are being sent earlier for surgery. It's interesting to me that the me that started practice nearly 15 years ago would have said "Oh, your disease is too small, you don't need surgery," right?
Mhm.
I I practice very differently now. I am excited when they come early because I know what it can look like if they don't.
Right.
I think if it's an area that already has a tract that is causing multiple flares a month, even if it's just one small tract, then that
Mhm.
should be treated. If you have one small tract that you get one flare a year and it's not interfering with your quality of life, that patient doesn't need surgery. But it's the ones that have the tract that just keeps on keeping on, because those are the ones that are going to be at risk for developing more disease in that area.
Because it's almost like the track feeds on itself, right? And
Mhm.
starts to expand. But for people with less disease burden, do you still do a wide excision, or are you doing deroofing procedures?
No, I still do a wide excision and close primarily, especially when the disease is small and it's easily amenable to closure,
Mhm.
just primary closure. Why not just cut it out?
Okay. And do you do deroofing at all?
I do not. I used to. I was on I don't know how many years ago. I was on a kick where I decided I was going to try minimally invasive HS surgery. It didn't work out. You know, it works for a period of time, but I found that the patients were coming back more frequent than the ones that I just did a wide excision on.
Ah, makes sense. So leave the minimally invasive surgery to me.
Yes, I'll leave it to you. You handle it.
For the derms.
When it's too much, then I'll take care of it.
Sounds good. Now, I've had two patients over the years where we resected their HS and we incidentally found squamous cell carcinoma. And I have another couple patients who we biopsied them, found the SCC, and then they had the excision. Are you finding incidental SCCs on your patients?
So I send all pathology because
Hmm.
I had one patient who had a wide excision of the groin, perineum, buttocks, and was sent home with local wound care to heal by secondary intention. And she never healed
Hmm.
over years,
Or-
open wounds, open tracks. And so just like with any patient who has damage to the skin or recurrent damage to the skin or an open wound that is non-healing for a long period of time, all those patients are at risk of squamous cell carcinoma. And when I had that patient, I did a literature search and I found one paper. I think it was from 1952 from a plastic surgeon who had 3 cases of HS that he found squamous cell carcinoma in. And he said, I think that these chronic wounds and tracts can cause cancer.
Mhm.
And that's it. Or at least the last time I checked. That was the only paper I found. But you would think that we would see more of it.
Yeah. There's some info in the derm literature. I think the last big meta-analysis I saw, there were a little over 50 cases in the literature. But for me in 15 years or so, having seen four, I think it's underreported and maybe even underrecognized because, when I think of the large blocks of tissue you remove, are the pathologists going through that entire block? No.
Yeah, they're probably not. If there's something that looks suspicious, then I will send that separate, which is how that one patient got diagnosed. Interestingly, she kept getting diagnosed as pseudo epitheliomatous hyperplasia. I think I had probably sent like 8 pathologies on this one. And the pathologist actually was like, please stop sending samples. And I was like, no. And finally, one came back positive. Unfortunately for that patient, in less than a year, she passed away. And her diagnosis was too late. But I
Yeah.
think that pseudoepitheliomatous hyperplasia is a precursor to squamous cell and should be treated as such, especially in HS patients. And those patients, if they don't have a negative margin, should go back for re-excision.
And it's interesting because the SCCs, according to the literature anyway, the SCCs in HS are generally well differentiated. But despite that, the prognosis is poor, lots of metastases and so on. But I think that The well-differentiated nature makes it more difficult to diagnose because then it does look like pseudoepitheliomatous hyperplasia. It looks like kind of inflamed keratinocytes.
Yes.
So I think it's really tricky, and it's one of those things that keeps me up at night sometimes. So, but it's good to know that you haven't found too many and you've done so many surgeries. So, Dr. Caffrey, do you have any parting words for us?
It's very, very important for patients who have HS to go to a dermatologist that is comfortable with the management of HS so that they can get one early appropriate treatment and then early referral to a surgeon. I see many, many patients who are managed outpatient by APPs who maybe are not as well versed in treating HS, and those patients tend to need more work on the optimization. I feel very grateful to have many dermatology colleagues who treat and take care of HS and are willing to collaborate. And if somebody needs some better optimization, I'm very blessed to have you guys who will be like, yeah, let's do it right now. So
Listen, and we're happy and blessed to have you. Our patients have benefited so much from your interventions. So thank you so much for joining us.
thank you for having me.
Today, we've talked to Dr. Caffrey about the role surgery plays in the management of HS. And a few key takeaways from my perspective include the idea that dehiscence can be almost expected after surgery. I think that's a really important paradigm shift here. Another point Dr. Caffrey raised is trying to avoid anatomic distortion if possible, especially in our young patients in the genital area. And she sometimes uses CO2 laser to affect change in that area without the distortion. So thank you for joining us. Please take a moment to download the Medscape app to listen and subscribe to this podcast series on HS. I'm Dr. Jeanette Okoye for the Medscape in Discussion podcast.
Thanks for listening to Medscape's In Discussion Hidradenitis Suppurativa podcast series with our host, Dr. Jeanette Okoye. Be sure to look for more In Discussion episodes wherever you get your podcasts. Check out medscape.com or the Medscape app for show notes, links, and more information on hidradenitis suppurativa.